What are the findings in this 2D echocardiogram? This echocardiogram in apical four-chamber view shows dilated left atrium and thickened mitral leaflets. Diastolic separation of mitral leaflets is reduced, indicating mitral stenosis. Regions of calcification are visible in both mitral leaflets. Such densely fibrotic and calcified mitral leaflets are seen in rheumatic mitral stenosis. Left atrium is dilated due to the hemodynamic load introduced by poor emptying in diastole. Thrombi can form in the dilated left atrium with stasis in mitral stenosis and lead to systemic embolism. RA right atrium, LA left atrium, RV right ventricle, LV left ventricle, AML anterior mitral leaflet, PML posterior mitral leaflet. This is an echocardiogram in parasternal long axis view in a case of rheumatic mitral stenosis. AOV aortic valve, AO aorta, dis-IO descending aorta. Dilated left atrium is seen posterior to the aorta and anterior to the descending aorta. Thickened anterior and posterior mitral leaflets open partially into the left ventricle. The turbulent multicolored jet from the left atrium to the left ventricle across the stenotic mitral valve is seen in the color Doppler image. Anterior mitral leaflet is thickened and doming with calcification at the tip and has a hockey stick appearance in diastole. Posterior mitral leaflet is thickened and calcified. It has moved anteriorly in diastole instead of the usual posterior opening movement. This paradoxical anterior movement of the posterior mitral leaflet is because of commissural fusion. Due to commissural fusion, anterior leaflet pulls the posterior leaflet along with it during the opening movement. Aortic valve is morphologically normal and is seen in the closed position in this diastolic frame. The two aortic cusps seen in this view are the non-coronary cusp in the anterior position and left coronary cusp in the posterior position. Right coronary cusp is not imaged in this view. Aliasing velocity of the color Doppler system is seen in the color bar as 61.6 cm per second. This image is of rheumatic mitral stenosis and is quite different from the mitral stenosis in elderly due to mitral annular calcification. Echo quiz, parasternal short axis view. Here is an image from parasternal short axis view and echocardiography. What are the findings and what are the possibilities? Echo from parasternal short axis view shows a D-shaped left ventricular cavity alongside a grossly hypertrophied right ventricle. Normally, the left ventricular cavity has a circular shape in parasternal short axis view. When there is right ventricular volume overload, the interventricular septum bulges towards the left ventricle and the left ventricular cavity assumes a D shape in diastole. But as the left ventricle contracts in systole, the pressure rises above that of right ventricle and the LV assumes a circular shape. When there is severe pulmonary hypertension associated with elevated right ventricular systolic pressures, the interventricular septum bulges into the LV both in systole so that LV cavity has a D shape throughout. In the echo image shown, right ventricular trabeculae can be seen as grossly hypertrophied as part of severe right ventricular hypertrophy pointed by green markers. See also the video on eccentricity index for right ventricular overload and echocardiographic index for separation of right ventricular volume and pressure overload in this channel. Here is a relevant journal reference. Here is a modified PLAX view on echocardiography in a cyanotic infant. What are your findings and interpretations? Findings are easy to appreciate as it is an annotated image. Parasternal long axis view is often the first view taken during echocardiography. Usually it visualizes the left ventricle, left atrium, right ventricular outflow region and aorta. Here we have a modified parasternal view to trace the great vessel arising from the left ventricle distally. Great vessel can be clearly seen as bifurcating into two branches. This appearance is characteristic of pulmonary artery. When aorta is imaged distally, the arch with great vessels will be seen. In this case, pulmonary artery is arising from the left ventricle, that is ventriculo-arterial discordance. Aorta was seen arising from the right ventricle in another view in this cyanosed infant. There was a small patent ductus arteriosus and a small atrial septal defect. There was mitral pulmonary continuity without any conus tissue intervening. No significant subpulmonic gradient was noted. Right panel shows non-turbulent flow in the main pulmonary artery in blue color. Overall, the features were consistent with transposition of great arteries. In transposition of great arteries, the systemic and pulmonary circulations are parallel, unlike the serial situation in normal individuals. Hence, good mixing at some level is needed for survival. The best form of mixing is at the atrial level. Hence, the role for balloon atrial septostomy for a cyanotic neonate with TGA. Significant mixing at the ventricular level or great artery level can also improve the survival. When a large ventricular septal defect and subpulmonic stenosis are present, the physiology is similar to that of tetralogy of Fallot with reduced pulmonary blood flow. In the absence of pulmonary stenosis, large VSD will cause increased pulmonary blood flow, pulmonary hypertension, and infants present with cyanosis and heart failure soon after birth.